Welcome everyone to Grand Rounds. We have two sets of speakers today with two quite different topics. So our first presentation is going to be focused on tissue donation and the rapid autopsy program that's developing. And we welcome Harry Sanchez, who's an assistant professor of pathology, and as well as Marcello DiStasio, who is an instructor in pathology. Dr. Sanchez is currently developing the Yale, or Dr. Sanchez and Dr. DiStasio, currently developing the Yale tissue donation program, which we hope will enhance both basic and translational research at the school. When fully launched, the program will enable patients with late-stage cancer to consent to donate tissue for research, as well as the component that is about rapid autopsy, where patients will be able to donate tissue in the context of a rapid autopsy program or a warm autopsy program, so that tissue can be taken and used for a variety of different purposes in my experience, many different labs. And it's one of the big advantages of this somewhat difficult approach. So without further ado, I'm going to ask Harry to start, and we'll go from there.
Okay, I'm going to share my screen, and hopefully you can see that okay.
Yeah, you just need to be in presentation mode. There you go.
Okay, perfect. Well, thank you very much, Dr. Weiner, for the introduction, and thank you very much for having us. As you said, we'd like to talk to you about the rapid autopsy program, which is really, there's nothing technologically new about the approach, but it's a way to get patients, I think, involved in the basic science aspect of clinical research, and it's a way to coordinate our existing resources so that we can get, sort of address the problem of getting high quality and sufficient quantity of tissue. And so our objectives today are to talk to you a little bit about this approach and its advantages for patients and clinical researchers, and we do feel there were advantages for both. To talk to you a little bit about rapid autopsy programs that already exist, and finally to ask for your input and your participation, so that we're still putting this together. Those of you with thoughts on how we could do this better, we'd love to hear them. Sorry, do that, and we'll go with that. The outline, I'd like to put the problem sort of in context, and talk about the problem of sort of human tissue for research from the patient and research scientist perspective, and then talk to you a little bit about how I think the rapid autopsy approach addresses some of those things. It's not a solution for everything, but I think it is a very useful addition to what's already in place. So problems for patients in the general public, or sort of the subheading, why you might not want, if you are a patient, to participate in clinical research. And I think this goes back to the problem that has been since the beginning of sort of formal medical research. Once people realized, physicians in the 1300s, that it was hard to study function without understanding form, people started studying anatomy. And at the very beginning, it was a small enough enterprise that only the most marginal people, executed criminals, were what was needed, and that was enough. But as interest spread, success became sort of more universal, and the approach became adopted. The supply of bodies for study was far short of the legitimate demand, and so it created this sort of underground network of supply, and people resorted to grave robbery. And when that wasn't enough, eventually in Edinburgh, murder to come by tissue, and that led to the Anatomy Act of 1832. And the reason that I include this is that I think the Anatomy Act, which addressed this problem, beautifully states the problem. Basically, you can't know the causes and nature of disease without studying tissue, but the supply of tissue is insufficient, and that can drive people to do very ill-advised things. And that's not a problem that went away in the 1800s. So on the left here, you can see this is an image from the Tuskegee syphilis experiments, or rather the study that started in 1932 and went on for the next 40 years, 400 unwitting volunteers for this program. And on the right is the front cover from the Immortal Life of Henrietta Lacks. She was a woman in her early 30s who developed cervical cancer, went to Johns Hopkins for treatment, and tissue from her cervical cancer was used to create a very successful cell line, the HeLa cells, but that was done completely without her knowledge or her consent. And so while all of these things may have had good intentions behind them and developed some results, the result is that human sort of tissue for use of medical research has this sort of checkered and sort of fraught past that I think generates the sort of suspicion that's still with us today, even when we try to do things as a profession that are for the public good. Now, there are still plenty of people who want to participate in research and do. And I'd like to say that I'm going to talk mostly about participating in the earliest phases of sort of basic science research. And that is something that's very difficult to do as a patient or just a member of the general public. Research is extraordinarily expensive. I think, the average NIH award is something on the order of $500,000. And it's not the sort of thing that most of us can put a dent in individually. And you can do work that helps, with sort of organizations and things, but you can't really you can't advance basic science work as an untrained person. You can, however, donate tissue. The problem with tissue donation as it currently exists is one of coordination, so that people do occasionally come to us and say that their next of kin would like to donate their body to the medical school or for research. And the problem is that it's sometimes hard on short notice to put together somebody who will receive that really generous gift. And I'm going to turn this over here to Marco, or rather to Marcello.
So yeah, I'm just going to point out a couple of issues for researchers when it comes to performing effective research into the pathobiology of human disease. You can do the next slide. Okay. So, if you want to study human disease, you have a few options. You need cells of some kind, and you need tools to study them with. And so there are a few model systems out there. Actually, I shouldn't say a few. There are many model systems out there, including cell culture, animal models, surgical specimens, and standard hospital autopsies, all of which are fairly readily available, but have their own limitations. Next slide. So, with certain tissue sources like cell culture, cell culture is an incomplete system. The tissue is not intact. And the cells are grown in media that may have a lot of factors in it, but they are not embedded in their natural environment. So it makes it difficult to model, non-cell autonomous functions. Animal models, of course, have contributed tremendously to our understanding of biology. But there are cross-species differences, and I'll just highlight a couple of them here. RB mutant mice develop pituitary adenomas as opposed to retinoblastoma. P53, essentially a Lee-Fraumeni type mutation in a mouse, produces sarcomas as opposed to the often mucosal carcinomas typical of the human patient with Lee-Fraumeni. And in terms of metastasis, there are models that do produce metastases in mouse, but spontaneous metastases are much more rare in mice than they are in human. So if you want to study human, it's best to actually look at human tissue. Yeah, next slide. So with human tissue, we have a few options. There are surgical specimens, but there is limited availability of certain tissues. And the tissue that is available must be retained and examined by a pathologist for diagnostic purposes before it can be released for research. I'm a neuropathologist. My research is in central nervous system diseases. And of course, brain tissue is extremely precious, and surgical removal is as minimal as possible. to minimize morbidity. So we have very limited access to that kind of tissue. And then there are standard hospital autopsies, which, while there's ample tissue available and often, consent is given, the status of the tissue is often the problem here. So with longer postmortem intervals, there's degradation that occurs. And also, the standard autopsy service on the hospital, accepts patients from a wide variety of sources, some of which are better documented than others. And so, one thing that the rapid autopsy program aims to do is to recruit, donors who are well known to clinical services and their, clinical researchers here at Yale. Next slide. So just to quickly highlight a couple of effects of postmortem interval. If you look at these histology images here on the right side, this was a nice study where they used surgical specimens and then basically just let them sit around for a few hours and see what happened to the tissue. And you can see that as the postmortem interval changes, I just want you to appreciate that there are changes from an immediately resected specimen on the far left to the 24-hour interval on the far right. And essentially what's happening there is there's breakdown of membrane integrity, proteins are denaturing, and you're basically losing the histologic structure, the histomorphology of the tissue, which can be limiting for our understanding of microscopic anatomy in that case. There's also molecular changes that occur. There's a lot of rhetoric around RNA, and postmortem interval is related to RNA. I can attest to the fact that grant reviewers get very touchy when it comes to RNA. I think it's actually a little bit overblown. The total quantity of RNA actually doesn't decrease that much, but there's actually a more insidious problem when it comes to studying RNA in postmortem tissue, which is that certain RNAs actually decrease or increase, right? Because transcription, your tissues don't necessarily know that your brain has stopped functioning, or that your heart has stopped beating immediately. So certain transcripts actually increase after death, and certain transcripts decrease after death. And so that can lead to substantial unquantifiable bias in your study, which I think is actually a more significant problem than total RNA integrity. And then for the next slide, there are also effects on proteins. This was a nice study that was done on cerebrospinal fluid, and looking at the effect of protein aggregation actually in the CSF over time after death. And so again, these are basically deviations from the normal physiology of life that are occurring, and therefore less representative of the state of your system during life. So these are all effects that we would like to minimize with the rapid autopsy program. Another limitation with currently available tissue is just in sampling. Surgical specimens, for example, we have to, as I mentioned, we have to minimize morbidity. So in the central nervous system, that you can only take so much. So this picture just shows a composite fMRI image of eloquent cortex. In other words, brain that you still need in your head. And so therefore is inaccessible to interested researchers. And so, of course, this stuff is extremely valuable for understanding the tumor environment, but we are unable to study it using standard surgical specimens. And that's important. It's important to have a wide breadth of tissue to study, both in space and in time, because we need to understand tumors both in space and time. We need to understand heterogeneity within the tumor. There are multiple clones within a tumor, some of which give rise to metastasis. There's evolution. We see molecular evolution. We see phenotypic evolution in tumors within the primary tumor, and we also see selection for certain features in metastases. So access to all of this tissue from multiple sites, multiple regions of the tumors is all essential for understanding the complete pathobiology of tumor genesis and metastasis formation. So,
Thank you. So what I'd like to talk to you about next is just some of the mechanics of what rapid autopsies actually are, and how they differ from a standard autopsy. And the short answer is that rapid autopsies are not technically autopsies. They are anatomic gifts. So an autopsy is a diagnostic procedure performed on the remains of a decedent, and permission can only be given by the next of kin, the legal next of kin. I cannot legally give permission in life for my own autopsy. That permission doesn't survive my death. However, I can give, and this is by virtue of some Universal Anatomic Gift Act legislation that's been adopted by most states in this country, I can in life give permission for an anatomical gift of part or all of my body for the purposes of transplantation therapy or research. And this is from the Connecticut statute. And the important thing about this statute, which governs organ donation, is that this permission survives my death and cannot be sort of rescinded or modified by my next of kin. So it's a durable gift. And it can be made not only for, as I said, transplantation, but to a hospital or a medical school, dental school, or university, specifically for research and education purposes. So this is what covers these things. As Marcello pointed out, the delay in standard autopsies is the thing that renders the tissue less useful. And we've looked at our own postmortem intervals. Over 2/3 of our cases are longer than 24 hours between time of death and start of autopsy. And most of that delay is due to consent delays and family discussions, which are important, but take place after death and sort of slow things down. So how does the actual process work? So what we propose is that research investigators contact us when they have sort of Yale IRB approved protocols, file them with us and talk to us about their requirements for tissue collection and storage. The clinicians and researchers identify patients, and you already have relationships with them, so that makes that easier, that might be interested. And if they are interested, walk through this very transparent and very thorough consent process. If the consent is given, we retain a copy of that at our program and provide contact information with the family. When the donor dies, we're contacted either by the family or the facility. The permission, we contact next of kin, and then we assemble our staff as quickly as possible, within an hour certainly, and we hope that we'll be able to get to the actual process within a few hours, hopefully no more than 6 and hopefully less. The idea is that we collect this according to protocol, save it in the appropriate way, and then hand it off at the first possible chance to the research lab who recruited this patient. And so we're not a tissue bank. We are just sort of there to smooth things over. I'll turn this back over to Marcello.
Yeah, I won't belabor this, but actually you can go right to the next slide. There are a whole host of modern technologies that have really come into their own, a lot of them driven by next generation sequencing, but also by new techniques in microfluidics and other high throughput platforms that allow us to just gather a huge amount of data from relatively small but high quality fragments of tissue. And so all of these highlighted here are certainly on the table. They've been performed in human tissue and validated. There are too many technologies to sort of enumerate, but a large number of them really yield the highest quality of data. And by quality, I mean high reliability information, which is basically, it's important to combat these issues of bias and being misled by artifactual changes in the tissue, which with these huge data sets, it's very easy to get sort of led down the garden path by those kinds of artifacts. And so the quality of what you put in really influences the value of the information that you get out of these high throughput, big data, new technologies. And so the rapid autopsy, again, we aim for that to be sort of the input to many different types of experiments. Viability, yes. So these are the limitations, again, things that we talked about, postmortem interval time, temperature, all these things can affect quality of tissue. And of course, clinical factors, again, just contribute to the value in that the information about the patient, having a basically a pipeline and good communication between the sort of basic science labs, the clinical researchers, and the clinical teams treating the patients, closing that loop, ideally through the rapid autopsy program where we can disseminate all this information, will again, you get the most out of these precious gifts that the patients donate. So just very, very quickly, a couple of results from similar programs around the country. Johns Hopkins has a pretty mature program. They've had a segment of it very much focused on prostate cancer, and they've shown a lot of really interesting things about clonal evolution in prostate cancer and how that contributes to metastasis in different forms, in the androgen insensitive and the androgen sensitive forms. Dana-Farber has a very advanced program. This is just one example of a breast carcinoma study that showed the amount of diversity in breast tumor metastases. But there's a lot of other research that's come out of that program. If we go to the next slide, just a couple more. The NIH actually runs a program out of their clinical center. And this, again, they had excellent records. This was a really exceptional case study in that they had tissue collected surgically during the patient's life, both of primary tumor and of lymph node metastasis, but also then they had the rapid autopsy at the end of the patient's life, which, together comprised just a tremendously valuable data set. And finally, the Live On New York, that's actually a transplant service, and Columbia has partnered with a transplant service to sort of simultaneously perform warm autopsy on consented patients, and that's enabled them to do all kinds of really innovative immunological studies. And this is just one example, looking at natural killer cell interactions and in their development in different tissues.
So just quickly to go through some of the programs that exist. This is not a complete list, but there's somewhere, I think, between a dozen and 15 of these programs, and I list them here in sort of order of proximity to us. And I point out that what these programs all have in common is that they are in areas that are metropolitan, have large patient populations. They're all based at academic hospitals with national reputations, and they all have a critical mass of NIH-funded clinical research scientists. And I think we have all of those factors in place, and I think we are in a position to set up a successful program here. And I'll just turn that over to Marcello to finish up.
So finally, yeah, just to summarize, the patients are offered an opportunity to make a very meaningful contribution to medical research that really could not be replaced by anything else. This kind of program promotes transparency and preserves autonomy of the donor, and really puts the donor at the center of a very important line of research into their disease. Researchers, I spend a bunch of time on telling you about different factors in tissue quality. Essentially, that's the core: good quality, good quantity tissue that's well documented and part of a sort of coordinated research team that includes the clinicians, the patient, the researcher, and the rapid autopsy program. So we, I don't know, Harry, do you want to maybe take this one?
Yeah, sure. So in trying to put this together, we've looked for input from a bunch of different sources, and we've had long talks with the folks at MSK and Johns Hopkins about their program. And we've had some really great conversations with the Yale Cancer Center's Patient and Family Advocacy Council and Community Advisory Board. So we've had, patient input and sort of existing RAP input. What we're looking for, hopefully today, is the input of some of our own clinical research community. And we'd like to invite you to weigh in and ask questions and hopefully participate. And this is where we can reach it, where you can reach us. We have the beginnings of a website, and here are our emails. And be happy to take any questions you might have.
That's great. Thank you very much. Let's just see if they're in the chat. A question that was asked: how do you recruit, connect with patients and families? I know that body donation is a very meaningful gift and legacy for many patients and their families. How can frontline clinical colleagues help support your work? And I'll just add to that a bit, which is, you talked about the fact that there was not a bank, but that you would be essentially delivering tissue to a lab. I think it's often going to be a program or an individual clinician who can do the recruiting. And I don't think it's going to be a lab per se that does that. So maybe you can address those issues.
Yeah, no, you're absolutely right. So the different hospitals use different models. So MSK, I think their program takes consent. Johns Hopkins, the clinicians take consent. And the ideal situation is to have a clinician who's also doing research, but you're absolutely right. I think it's really the clinical care team that has to approach the patient. They have and they have to identify people who they think might be interested and might be willing to broach the subject.
If a second question, if a patient dies at home, how is it that the patient's body reaches Yale?
Yeah, so what in those cases, what we have a contract with an area funeral home that has agreed, obviously, for a fee, to make that transport to Yale.
And finally, would you prioritize certain disease areas for patient recruitment in the initial rollout, or would it be up to each and every clinical research group? And again, I'll add to that and say, I think it would be really helpful if we could pilot this in a few areas, getting the clinical people in those areas interested and invested. Do you have thoughts about that, though?
Sure. Yeah, Marcello, do you want to take that one, or?
Sure. So I think we have a lot of interest from neurology. Obviously, this is one of the main avenues for central nervous system tissue. And so we have a number of clinicians and research labs sort of already sort of preparing, particularly neurodegeneration, but also stroke. And I think again, part of our purpose talking to this group is we think that the Cancer Center, would be an excellent, basically place for us to connect, with all the research that's happening in the labs, run by Cancer Center PIs and the clinical teams here. So I think essentially these two areas are probably our first two rollouts.
Yeah, and I can tell you that our lead neuro-oncologist has already jumped in to say that he is happy to pilot.
Great, that's wonderful.
Thank you, Antonio. With that, I'll thank you, and we'll move on to something entirely different. Monica, do you have a presentation yourself, or are you going to introduce other people? You do. Okay. So we're going to hear three presentations from Monica Fradkin and from Christina Matousek and from Mandeep Smith that will be presented at the Oncology Nursing Society. And with that, I welcome them all.
Thank you, Dr. Weiner. I'm Monica Fradkin, and I'm here sharing a presentation that we did at Oncology Nursing Society Congress last week, and I'm going to spend a few minutes talking about the ambulatory oncology transformation, specifically around one working group. And I'm here, there were multiple people that were involved in this work. Ann Chang, Jeremy Kortmansky, and Connie Engel-King as a consultant. And then I will give a high level of the work that we've done, and then I'll hand it over to Christina, Matousek, and Mandeep Smith, who are the leads of one of the work groups that have patient visit readiness, to kind of show how we took this ambulatory work and put it into real practice. So with that, how did we get started in all this work? And back in March of 2020 and April of 2020, we really had to change everything we did about how we provided ambulatory care. We consolidated clinics. We moved all of the New Haven teams and clinics out to the network to different sites to provide additional capacity for inpatient. And with that, what we learned is that while we were forced to do this, there was an opportunity to relook at how we provided ambulatory care. And so we, Kim Slusser, Lori Pickens, Kevin Billingsley, at the time said, how can we create a new normal and make one Smilo and really make this a 2.0, version 2.0. So there was an ambulatory transformation steering group that was started, and it really looked at the ambulatory flows from before the patient arrived all the way through to when they left. And there was a steering committee. And within that steering committee, there were 6 different subgroups. The subgroups were around facility and environment, patient access, technology, staff and staffing, and then communication. And the final one in orange is really the care delivery workflow subgroup that we're going to talk a little bit about today to share what we've done. But each one of these groups are, as you know, are all interconnected. So how we do this really had to be done thoughtful and coordinated. So the approach to this is that we had to have a multiple steps in order to even understand where we were. And I'm going to go into the detail of the elements on this slide into future slides, but we had a 5-step process on how we approached this work. And the first thing that we had to do is we had to understand where we were, what was our current state. And in order to do this, and we wanted to make sure that we represented all the areas across the ambulatory enterprise. So a key survey was created. We obtained information around role, where people worked, as well as what team they were aligned with. And there was a structured and unstructured questions. We wanted to know open comments, which provided a significant amount of information. And when you think about analyzing and aggregating the data, we had, open-ended questions can provide, a whole level of analysis that was created. The workflows that were not included because they were part of other working groups was the supportive care services and the access call management and intake was all part of other working groups. So we really focused on the clinical flow of patients. The survey was open for 8 days. We had almost 200 people respond, which shows that there was a real opportunity and engagement from all different roles and disciplines. So we had a nice mix of responses, 26% from physicians, 32% from nursing, but we had pharmacy, we had lab, we had access staff, research, everyone, we had multiple people that, roles that completed this, as well as modalities. So 2/3 were medical oncology, but we had a nice representation of radiation oncology as well as surgical oncology. And what's not on here is that we had a 50-50 split of the New Haven teams and the network. So we really did get a great representation of the information that we were looking for. So once we took that, we spent a tremendous amount of time aggregating and analyzing the data, but there were 10 common workflows that came up as the opportunities for improvement. And what a group of us did is we priority ranked them, and there were about 70+ people that were involved in this. And the priority rank also needed to intersect with the different working groups that were also functioning. So while this is a high level of the 10 different groups, we had to create different subgroups within those teams. So there were 3 different COVID-related projects, and we deployed them to the COVID team. There was a working group already that was in place that could handle and manage those groups. But the non-COVID related really fell into 4 different buckets that you can see here. We had more than 70 participants, physicians and staff of all different roles, as well as sites that were represented in these different groups. And for clinic flow, we had 3 different working groups that are still actively working and meeting and right now. Visit type criteria was a proactive approach on how we could identify patients that would be televisit appropriate, that would help minimize switching visits last minute, and being able to designate those visit types. The patient visit readiness, which Mandeep and Christina will talk about, is really also about the patient and physician having the optimal visit and what can be done beforehand and after to ensure that those patients experience that visit. And the checkout process is also an active working group around that communication of what needs to be done following the visit to ensure that things are communicated and followed through on, whether it's referrals, orders and imaging that have to be done, or next visits. Infusion flow was really around labs and advanced release of chemotherapy, but at the same time, there has been an initiative that we're implementing lean toss across the ambulatory areas where infusion is done. So we are working on lean toss right now. And then patient education was really around how can we utilize and leverage technology to provide patient and family education, especially when there's limited patients and family members that are allowed in clinic, that there's a way to do this in this more of a video, telehealth forum. And then imaging is really, we've heard a lot about access challenges for scheduling and how can we work together across the discipline with imaging to get patients scheduled timely and appropriately at the right location. So while there are a lot of moving parts in all these different working teams, we had a template of how we would move forward with this work. First, we needed to understand workflows. We needed to do observations and did process mapping and really identifying barriers that could impact the flow. And then we had to just test it. And so we were piloting different initiatives. We had to be really selective on how we determine the site, what teams, how are we going to measure this? Because the goal ultimately is that this is sustainable as we continue to move forward, and what adjustments we had to make, using rapid change cycles. And finally, the goal is that once these pilots are really done, is that we get this out everywhere. We want to be able to utilize our, these efficiencies and opportunities to really go across, which will enhance the Smilo 2.0. And so this is just to understand there were multiple tools. As I said, we want to be able to sustain this work. So we created within Epic, there are tools. We created standard operating procedures. We looked at the literature of what is said that on the work that we're doing to validate that what we are doing makes, is aligned with what else is happening out around the country. We created metric-based reports so we could share data so that people understand how they're doing and where their opportunities are, and to celebrate the successes. And finally, ASCO came out with some telehealth standards at the same time we were doing this work to ensure that we were doing the work that aligned with the ASCO standards. So these are the high level work that was happening. And now what I'd like to do is switch it over to Christina and Mandeep to share how the work of the Patient Visit Readiness Project, has taken the framework of what I have shared into a pilot. Christina and Mandeep.
Thanks, Monica. So as Monica alluded to, our project was really on patient visit readiness. Next slide here. Which has been showing that really patient visit readiness is essential, and it's an essential component of patient safety as well as clinic flow in our ambulatory setting. So this included basically just making sure that your patients that were coming in were completed, all the prep that was done ahead of time was completed. The next appointment, disposition was actually completed prior to the current visit that's coming up, and making sure that any consults, labs, any imaging or studies, or any prior authorizations that were required are being done ahead of time as well. So what we realized is that without the adequate preparation that was going on, there was significant delays within the clinics, errors, sometimes last-minute cancellations for patients, and an overall patient or provider satisfaction had decreased. And as Monica had mentioned, there was multiple surveys. There was survey questions that were congregated and reviewed, and within those visits, what we realized is that there was our practices concerning pre-clinic prep and post-clinic wrap-up found there was multiple variations within our health system. As you can see in this slide, you see that about 80% of the team did some sort of prep before, but only about half of them really had some form of guidelines to follow or best practices within the clinic prep. In addition, a vast majority of teams were also not doing any sort of post-clinic huddle, and most patients were leaving without any follow-up appointments, which again brought concerns to the team. We also surveyed clinic prep activities and found that the majority of respondents, 84%, do review the schedules ahead of time, but again, half did not use any standardized criteria. And in addition, about a third do not review test results, a fourth do not communicate or review missing orders, and lastly, less than half did not evaluate ahead of time which patients could benefit from a nursing visit. Next slide. So when doing the literature review, as Monica had mentioned, there was lit reviews being done. And in it, what we realized was that we were starting to work on this initiative and needed to really look at the ambulatory areas and see, what was happening in other areas. So a major article that we reviewed was published in 2021, which found that researchers were performing a systemic review of 49 studies that ranged around 10 countries and highlighted about 8 pre-visit planning techniques that could be used. And with this review, it really suggested that preparing for clinic can enhance the quality of patient care as well as patient to provider communication. And 84% of the authors reported that proactive visit patient preparedness was a really effective way to improve patient-centered care. So when looking at what we've talked about, which is patient visit readiness, what does this actually mean and how do we achieve it? We needed to define this. So visit readiness really begins with your post-clinic wrap-up from the prior visit, as that will be outlined with an RN or a scheduler, at which time then you are looking at your next visit and really reviewing what is required for those. Pre-clinic prep sounds obvious. This is a proactive approach of reviewing what the practice nurse is looking at and all the elements that need to be completed before the patient comes in for the visit. And how do we achieve all that? It's through completion of your provider disposition to guide the pre-visit prep, as well as the defined team huddles to improve communication for all the teams. And then this can all be done virtually or in person, weekly, daily, or really whatever works for your team. But it allowed you to have the what, how, and when of what patient visit readiness looks like. Next slide. Slide 16 really just depicts the team. This is Dr. Kortmansky's team. And the post-clinic huddle that they run is usually done weekly on Fridays. And as you can see, he did it in person with his team. This also acts as a wrap up for the general elements that are being done within the clinic. What we found is that it engaged the staff in increased efficiency, communication, and collaboration. And these huddles can really be customized to each team and what exactly you're requiring for your team. However, we did outline key players for each huddle, meaning the practice nurse, the provider, and the scheduler. And I'm going to hand it over to Christina now. Christina.
Thanks, Mandeep. So when we began our process a long time ago, we developed this Vizio Map, which really outlined every element from checkout from the previous visit to the next visit that they were being seen, to really understand this process and how we can improve this across the health system. We further broke this down and to the left-hand side where you can see the different swim lanes that looked at the responsibilities of the provider versus the practice nurse versus the schedule, as well as we incorporated the medical assistants or the ACAs. It was a lot of work to do it in this way, but it really helped to us to understand where we needed to improve our process. Next slide. So since we discussed the different elements that we focused on, we actually did develop some tools that were meant to be helpful for pre-clinic prep purposes and to lessen the workload of the practice nurse who is performing the pre-clinic prep elements. So the first is what's called the Onc Summary Nurse tab. It's actually located in the multi-provider schedule. It allows the practice nurse who is performing the pre-clinic prep one-click area to go through the different elements that she may find helpful to the pre-clinic prep process. So this was developed to hopefully reduce the amount of time that the practice nurse has to spend doing pre-clinic prep. It involves many elements and components to the report, including treatment plan, the actual follow-up disposition from the previous visit will be there so that they can actually understand what is needed for the next visit to help streamline this process. So you can go to the next slide. The other feature that we developed is what's called the Visit Ready feature on the multi-provider schedule. This is a column that anyone can add to their provider schedule. And for those that are currently in the pilot phase, the physicians will actually see this being done in their areas. But you can see that once the patient is deemed visit ready, the practice nurse will actually go in and make the patient a green check for yes or a red X for no. We also included a column for visit ready comments, and that allows the practice nurse to make comments in that specific area so that number one, it can remind themselves of who's visit ready and who is not, as well as what they need to follow up on for that particular visit. This is also viewable by the provider if you wrench it into your multi-provider schedule, so that the providers are able to see their clinics prep as well. You can go to the next slide. So in order to convey this new workflow, we performed formal team trainings to discuss this with each individual. That included the discussion of the workflow itself, the huddles that we wanted them to do, as well as the tools that we developed to help streamline this process. We also offered initial first huddle guidance and facilitation for the new members that were being part of this pilot. And the session involved all team participants and were completed prior to the go live. You can go to the next slide. So as we have alluded to, this has been a really big work in progress. We currently have North Haven, Guilford, and Greenwich underway with our pilot sites. North Haven was our first site to go live in October of last year. Greenwich currently went live, I believe, last week. And we also have planned sites that are going to be going live in the near future: thoracic oncology, head and neck surgery, GI med-onc, as well as classical hematology and malignant hematology in North Haven. We also have incorporated Trumbull as well. They're not on this slide. But again, this is a work in progress and a huge team effort. You can go to the next slide. So now on to the data. So we looked at many elements when we created this workflow, and one of those included physician disposition compliance rate. This data represents 3 physicians from the North Haven site, which looked at data from pre-pilot to April of 2022. So as you can see, the provider C in the green line really was compliant with this throughout. They acted more as our control line or participant. And we saw that as we went into October, we saw a gradual increase in provider A during the pilot phase and tapering off into about a high 90 percentile of completion, as well as provider B as well. Go to the next slide. So in addition to the provider compliance, we also looked at practice nurse preclinic preparation compliance rates. This represents graphs in the Helix report format that we looked at from North Haven and Guilford. So you can see that North Haven had a huge uptick in their compliance when they actually started the pilot in October, and they've really maintained that compliance rate into the above 95% throughout their time in this study. Within Guilford, they went live in February of 2022, and you can see that with them, it was a little bit more of a gradual rise in compliance, but overall has again tapered off into a great compliance rate for the remainder. You can go to the next slide. In addition, we also looked at patient visit unreadiness volumes and reasons for why patients are deemed unready for their visit. For North Haven, we calculated that about 17% of patients, 170 out of 1,098, over the course of 8 weeks were not visit ready, as well as Guilford, which was about 22%, or 206 out of 930 scheduled visits. And we listed the actual categories for why this was, but we actually found that the most common theme was the test ordering and scheduling, that they were not performed or testing was not completed in a timely manner by the patient. We'll go to the next slide. So in addition to our data collection, we were also really interested in feedback from the end user and asked them to respond to the following questions that you can see listed here. For example, we have seen that the doctors have found fewer interruptions. They can review cases at the same times. And our nurses have found that the huddles have really helped manage patients efficiently, as well as some of the other providers noted that improving the preparation really highlighted what patients did not have done prior to their visit. We'll go to the next slide. So during this process, we definitely learned a lot, including the fact that specific tools can really streamline the process, but it also requires training and consistent utilization. In addition, consistency with performing huddles, as well as physician leadership and engagement, is really a key player and a huge role in the success of this initiative, especially with regards to the disposition completion and leading post-clinic huddles in a consistent manner. Next slide. So for our next steps, as we look to the future, we plan on working with IT to refine our compliance tools and really refine our Epic related tools based on feedback from the end user. And we will continue to perform a systematic approach when rolling these out to really ensure success of this program. For those in the ambulatory setting, we'll likely be working with you in the future, with you and your teams to help improve your clinics and enhance patient preparedness. And we really look forward to your collaboration during this huge team effort. So thank you so much for your time, and we will now answer any questions that people may have with Dr. Kotlansky as part of the discussion as well.
Thanks very much. Questions?
The only thing there's a couple things. One, that we also are looking at the Preskani. We have to understand what the meaning is for patients as we're doing this work. So we're looking at the Preskani aspect of this work. And the only other thing I didn't get a chance to say is there are so many people that have been involved in this, the practice nurses, the access team, pharmacy, obviously the physicians, the APPs. And I just want to say a huge thank you to all of them, as well as Christina and Mandeep. You know, and Jeremy, I'm going to ask you if you have any kind of pearls or words of wisdom that you might offer as an end user of this work as we, you know, finish up.
Sure. You know, I think for our team, this meeting has really been transformative for our group. And while there is a core group that I think needs to be there, which includes the physician and the practice nurse and PFAS, I think that the larger the group is, the more productive those meetings are. And we have included in our meetings our APPs, the infusion nurse, as well as pharmacy. And in doing so, you really capture all of the different ways that we need to prepare for the visits, not just including whether a scan has been scheduled as ordered and will be available in time for the visit, but also where chemo orders need to be entered or informed consents need to be completed. It's dedicated time to review the schedule with PFAS. I think all of us, you know, have these long lists of patients that have acute issues that we need to get in. And rather than being disrupted all throughout the day to figure out when that should be, we now have dedicated time to do that. As a physician, it also allows me to follow up with infusion nurses and the APPs to find out whether there are any urgent issues, dose modifications, things that need to happen with patients that I hadn't seen that week, so that everybody on the team is really understanding where all of the patients are in their course, you know, who we can anticipate might be progressing or is having a lot of trouble, where, you know, there might be flags that we say, oh, we need to bring in OCM or social work or palliative care. It really is a holistic approach that can only be done when you have some dedicated time. And while I know that for my team, we take an hour on Friday, I understand that not everybody has that much time. But in that hour, we review all of the patients from the week that was and all of the patients that are in the week that follows. And so it can be done in a shorter amount of time by just breaking it up into fewer days to review.
You know, Jeremy, I think that I think this teamwork is really essential. I think it can be done as an hour that you set up. I think that in some cases it needs to be a huddle in the morning. But I think it's really important. One of the things that can happen in that huddle on the day of treatment, or for that matter, the week before, is to identify patients where if it gets busy, that person might be able to be shunted to the infusion room because you know they're going to get a treatment anyway and see you afterwards, as opposed to, you know, waiting for everything. The one question I have is, and you may have said this, but to what extent have you been successful either in New Haven or at some of the other sites in pairing infusion nurses with physicians, so that a physician isn't necessarily working with every infusion nurse in the infusion room? And maybe you do that. It's just my experience in the past is that that has been challenging. You're on mute.
Yeah, we actually haven't, with this work, we have not focused on the pairing or the team. I mean, we definitely have an infusion nurse as part of the huddles, because whether it's the charge nurse that represents the infusion, but we haven't done that. And with lean TOS, I think we're going to have to, you know, we're looking at it a little bit differently. So I'm not sure what that will look like just yet. So I guess to be determined.
Yeah, I know we had looked at it initially in hematology a long time ago. And with the move from New Haven to North Haven, it kind of it didn't work correctly, but I do agree that there's a lot of value in that.
It's always challenging with schedules and what have you, although my strong sense is that there's a real value of pairing physicians with maybe not one person, because that one person could be off, but 2 or 3 or 4 people as opposed to 15.
Right.
In any case, I just want to say you all have done a great job. Thank you so much, both for presenting the work, but more importantly, for all the really great work you've done, and there'll be more to come, I'm sure.
Thank you so much for the opportunity.
Oh, thanks, all of you.
Yes,
Thank
thank you
you.
so much. We appreciate it.
Thanks, Jeremy. Bye-bye.
Bye.
Bye.